good afternoon or good morning, depending on where you are coming in from today. We've got about 42 people on, and so to stay on schedule, I'm gonna kick it off with some little orientation slides. I wanna welcome everybody today to today's session. My name is Vanessa Carson-Sasso, and Liz, if you could go back to the, thanks so much, Liz. And I'm the treasurer for the National Alliance for HIV Education and Workforce Development, NAHUD. And joining me today is Liz Lazo, NAHUD's secretary. And today's webinar is the fourth session in a 7-part national webinar series hosted by NAHUD in partnership with the AIDS Education and Training Centers program and the Opioid Response Network, ORN. We are recording today, and we will make a recording available as well as the slides probably within 1 week of today's webinar. And next slide, please. So NAHUD is a membership organization of 8 regional AATCs and 2 national AATCs, again, AIDS Education and Training Centers. And we support the AATC program mission in collaboration with NAHUD, which was established in 2010, which is essentially the professional organization for the AATC program. The AATC program is funded by HRSA. It's part of the Ryan White program. And essentially, we are looking to build and maintain a well-educated and culturally sensitive health professions workforce that can provide prevention, diagnosis, care, and treatment and medical management for people at risk and living with HIV. Next slide. So since 2018, NAHUD has been funded by the Opioid Response Network, which is a SAMHSA grant. The prime recipient of that grant is the American Academy of Addiction Psychiatry. And NAHUD is part of the ORN network, which is about 40 TA providers across the country. And ORN was created to support efforts to address the prevention, treatment, and recovery of opioid misuse. So the ORN provides free resources and technical assistance locally in communities across the US and its territories. And you can check out the ORN website listed here on the screen to learn more or to submit a TA request yourself. Next slide. So today's session is accredited. We will be offering CME, CNE, social work, and also a certificate of attendance. So please go ahead and complete your evaluation at the end of today's session within 2 weeks in order to receive your credit or certificate. But most importantly, we do value your feedback. Again, this is a webinar series, and we are taking all feedback into account as we move through this process. So please, please, please fill out your evaluation. It is super meaningful to us. And a link for the webinar will be inserted into the chat towards the end of today's session. Next slide. So this is just a little bit about how it will work if you are seeking either a certificate for continuing education or for a certificate of attendance. And so with that, I am very honored to introduce today's speaker, Dr. Sandra Springer, who is an associate professor of medicine in the Department of Internal Medicine, section of infectious diseases at the Yale School of Medicine. She is an attending ID physician at the VA in Connecticut and the director of infectious disease clinic at the Newington VA site. She has significant clinical and research experience with persons with HIV and substance use disorders and is board certified in internal medicine, infectious disease, and addiction medicine. She is the director of the research program In Stride, integrating substance use treatment research with infectious disease for everyone at Yale School of Medicine, where she and her team conduct clinical research on the integration of SUDs and infectious disease and HIV treatments. In particular, is focused on evaluating medication treatments for opioid and alcohol use disorders to improve substance use and ID HIV treatment for persons involved with the criminal justice system. She currently is the PI on 6 NIH awards and 1 VA randomized controlled trials evaluating the impact of long-acting injectable buprenorphine and naltrexone among persons with OUD released from prison and jail, among hospitalized patients with comorbid infections, and among veterans with OUD. She has presented her research numerous times, both nationally and internationally, and has published over 100 manuscripts and book chapters. So we are just so grateful that Dr. Springer has taken the time today to present to all of us, and I'm really looking forward to it. So without further ado, Dr. Springer.
Thank you. Thank you very much. That was a really nice introduction, and it's really an honor to be here, and I appreciate you inviting me and all of you that are here to, to attend this. So I'm going to speak to you today about the incredible importance about how we need to do a better job of integrating substance use disorder treatment, in particular opioid use disorder treatment, to not only help improve HIV treatment outcomes, but also prevent HIV, specifically among justice-involved persons. These are my disclosures. And as you have already seen, the goals of the talk are just to review what we know about the epidemiology among this population in the United States, as well as how the intersecting epidemics are worsening in this country, and how ongoing substance use, in particular opioid use, we are actually seeing increased HIV outbreaks in this country, and how it's so important to screen for substance use disorders, including opioid use disorder, to have a potential reachable moment to be able to evaluate and offer effective treatments for individuals who are in the justice system to integrate with HIV prevention as well as treatment services. And this, as I'll show you, could improve not only directly reducing opioid harm, so reduction in opioid overdose, but also importantly, with integration of prevention and treatment services, could lead towards ending HIV. So improving viral suppression and, of course, preventing new infections. So why the United States? This is a little bit older slide, but sadly still true. The United States incarcerates more individuals, than any other country. And we are not really seeing a reduction in that, sadly. If we look at, I'm going to talk about more closed systems, so prisons, jails, and others across the country. But we can't forget about the community supervision program, so parole, probation, where there's far more individuals involved in that system. But here, this is just looking at a depiction of our jails, our state prisons. We also have federal prisons, and we cannot forget juvenile detention, as well as immigration detention in other areas. If we look at individuals who are incarcerated, in particular in our state and federal prisons and jails, as shown here, we're very familiar that the majority are incarcerated for, unfortunately, drug-related offenses, 1 in 5. And if we look at who is making up this population, as we also know, unfortunately, a lot of other inequity here, predominantly Black, Latino, men, as well as Black and Latina women, make up the majority of our prison system. And if we look at the prevalence of what was used to be called DSM-4 substance use disorders, and red is recent and blue is lifetime, you can see there's a marked higher percentage of alcohol, drug, and serious mental illness compared to in green, the community setting. So high prevalence of substance use disorders and mental illness in this population. And while we have seen a slight reduction in the incidence or prevalence of HIV in our state and federal prisons systems overall across the country, it's still roughly the prevalence is roughly around 3 to 4 times greater than in the general community. So there's a huge number of individuals, a lot of racial, ethnic, inequity, as well as substance use and HIV. And the truth is, the majority do not stay incarcerated. The majority will be released to the community. And we also know that people don't stay in the community. Sadly, there's a significant recidivism problem, and a majority will be reincarcerated. If we look at what happens to individuals when they re-enter the community, relapse to drug and alcohol is very high. This is some older data, but pretty similar, that the majority will unfortunately relapse quickly. And it usually occurs within a few days to a week after release, regardless of the time of incarceration. And that in turn is, of course, associated with higher morbidity from opioid and other substance use outcomes like overdose. But also, if one has HIV and being released to the community, this ongoing substance use can interfere with their ability to adhere to antiretroviral therapy, as well as if on hepatitis C treatment, difficulty with that. And this can then lead to increased morbidity and mortality for the individual, as well as from a public health standpoint, if one partakes in high-risk behaviors like condomless sexual intercourse or sharing injection drug use equipment, that this can be an increased risk for those who do not have HIV. In terms of the mortality data from overdose, this is older data from Ingrid Binswanger and her group out of Washington State, but again has been shown numerous times that overdose is a leading cause of death of all individuals, as this is being shown released from prison, but we also know from jail. And this is just showing all causes of potential of a death. And if you look at the bottom here, sorry, the slides are going faster, overdose is the major cause with an odds ratio of 12.2 compared to in red, the community risk of death. And this is true because as one is without substances, typically most justice settings have used abstinence-based treatment, which we know does not work. And with the return to the community, there's an increased risk of craving and use, and then the tolerance has been reduced while incarcerated. And so a smaller amount, or even the same amount if you were returned, can increase the risk of overdose. And as we know, with fentanyl, illicitly manufactured fentanyl everywhere, which is more potent, the risk of death is even higher. If we look at how what happens to individuals with HIV when they are returning to the community after incarceration, there's a significant amount of data to show that the HIV care cascade is significantly interrupted. This is older data from the Texas Correctional Health System, published by Jacques Belligeron and colleagues in JAMA many years ago. Really what the point was is they were looking at what happened to individuals who had HIV, who were released to the community in regards to their ability to adhere or fill their antiretroviral treatment prescription. And the figure on the right, this is looking at days after release on the x-axis here. So 10 days, 30 days, 60 days, and the percentage who filled their antiretroviral prescription. And unfortunately, 5% were able to fill their prescription at 10 days post-release. And then upwards of 60 days after release, only 30%. So this lack of the inability to stay on antiretroviral therapy, and there are a whole host of factors associated with this. But importantly, we have to remember Texas, large geographic territory, but this issue of transportation to get to a refill center or pharmacy, which is also true here where I am in Connecticut. We don't have a great public transportation system. So if you don't have to be a big state like Texas, as well as there was a significant racial disparity as well, which we know probably is secondary to structural racism and other areas. But the importance of filling antiretroviral therapy, having the ability to take a prescription and be able to have it filled in a pharmacy in order to not have an interruption in care is critical, as well as, of course, health insurance. Work that I've done in the past with our group has specifically looked at what happens to actual HIV viral suppression. So that's our goal. When we treat somebody who is living with HIV, we want to make sure they're staying on their medication, but also achieving the ability to suppress their viral load to the lowest level of detection. This was looking at the Connecticut Department of Corrections, individuals who had HIV in an earlier period of 1997 to 2004, and there's been subsequent data published after this to show the same thing, but a significant number are offered antiretroviral therapy, and at this time, almost 60% had viral suppression before they were released, but the sad truth was that in a short period of time, only 3 months post-release, only 18% had maintained viral suppression. So it's an unfortunate issue. So we know that if one cannot stay on medication, they're less likely to have that viral suppression, but this was clear data. There's a whole host of factors, as I said, that are associated with this, which includes, insurance and transportation, housing, other basic needs. But we also know that substance use, as I've said, can interrupt that care cascade. And so it's really important that we identify comorbid other medical diseases that could interfere with their ability to stay on medications, and importantly, substance use, as we just described, not only increasing risk of death, but also can interfere with one's ability to actually be able to seek medical care and receive continued medication treatment for HIV. So the public health impact, of course, is can't be understated. That we know that if individuals with HIV, apologize for the slides going on their own, but if individuals with HIV are not able to continue to take their medication, the HIV viral load increases. And if one partakes in condomless sexual intercourse or sharing injection drug use materials, there's a significant concern for not only worsening their own health care and death, but also transmission potentially to the uninfected population. And so it's not just, I won't have a lot of time, but it's not just, opioid use disorder and other it's also stimulant use disorders. And we know that even with alcohol use, there can be an increased risk of HIV. So although I'll be talking a lot about opioid use disorder, not to forget that. So we also need other harm reduction strategies as well, like access to syringe services and other harm reduction strategies to reduce transmission as well. So this was just a brief overview article we did a long time ago, but looking at other important factors that can help someone as they're transitioning into the community again, they are living with HIV. So there's case management, linkage to care models, adherence support, diagnosis and treatment of co-occurring mental illness, housing needs, et cetera, and other risk reduction strategies as we discussed. But treatment of substance use disorders is what I was going to discuss. So, I've just given you an overview of the justice system and the epidemiology of HIV, substance use disorders, and other things. But really, to bring this home, as we're seeing individuals released to the community, back to the community, we're also facing, as we know, a significant opioid epidemic as well as co-stimulant epidemic. And I just always take a moment here because I went into HIV because of my interest in substance use and they were intertwined. But I was, coming up in my early career in medical school and others during our early AIDS epidemic, which we cannot forget in the Northeast was really affecting individuals who were had a history of injection drug use, were using at that time heroin, crack cocaine, was really affecting Black and Latino populations, many of whom were in urban settings, really without a lot of directed needs. And we had methadone at that time. And then we also found out that syringe services really reduced HIV occurring in this population. But other than that, as an HIV provider back then, I really could only refer to methadone. I couldn't do too much myself. We saw a reduction in new HIV cases. And then, as we all know, we hit our what we all know now as our current opioid epidemic. And, as I won't belabor this, but if you have, the only way you wouldn't know about it is if you're hiding under a rock. But, the current opioid epidemic was originally fueled by prescription opioids. And then, as we know, we started seeing an increase in black tar heroin coming up from Mexico, which was following the prescription opioid epidemic. It was easier, less expensive to obtain, and then it's just well known now that it's really fentanyl, illicitly manufactured fentanyl, being manufactured all over, that is really just driving our opioid overdose deaths across the country, to the point where now the opioid use, as well as with our COVID pandemic, has reduced our life expectancy in this country. As I mentioned before, although I am talking about the opioid epidemic and integrating opioid use disorder treatment, we cannot ignore the stimulant epidemic in this country, which does not show any reduction in abating. This is showing cocaine, which is the main stimulant we see in the Northeast, but across the country, methamphetamine is driving a lot of new infections, as well as either combined or alone increased overdose deaths. A lot of people don't know this, but stimulants on their own are contributing to a significant number of overdose deaths. I won't talk too much about it, but it's not just driving HIV, but acute hepatitis C and other infections like bacterial endocarditis. So we were all wondering what happened in the pandemic, and early on, there was evidence to show that opioid overdoses were increasing. And this is data from the CDC looking at the pre-COVID months in the light pink to the earlier, the height of the pandemic, as we all remember, April, May, especially here in the Northeast, where deaths were starting. It was obvious deaths were going up, and data was available later. All drugs on the first column, and the one in the red here highlighting synthetic opioids were really driving the majority of overdose deaths, along with cocaine and methamphetamine shown on the other two columns. So at that point, over 81,000 drug overdoses had occurred. And this was if we remember, there was that brief data saying that around 2017 to 2018, there was about a 4% reduction. And many of us were saying, well, that might be in certain states, but we're seeing increases in other states from fentanyl and others. And there was, sure enough, an increase. This is just the map geographically depicting synthetic opioid overdoses occurring across the country from 2019, June to May of 2020, again from the CDC, darker red being over a 50% increase. And areas that hadn't seen fentanyl, like the Midwest and the West, were just you could see a marked increase in overdose deaths from fentanyl. And this is not depicting the co-stimulant epidemics that were going on. I like to highlight this paper because this group actually disaggregated the data and really looked at the actual number of deaths per month and looked at over time. And so in red is 2020, but in orange 2019, and the other years are color coded. And May of 2020 was the deadliest month of that time. Over 9,000 individuals just in the month of May died of overdose, which was actually a 58% increase compared to May of 2019. And if you go into this paper and look at the detailed information, it goes state by state. And actually the numbers are far worse than what the CDC showed. And as we know, over the last year, we've seen an even further increase in overdose deaths to over 93,000 individuals. So this epidemic in itself is not abating. We are also seeing the direct association of this current opioid epidemic on fueling new HIV epidemics, as well as hepatitis C and other infectious epidemics. So just to remind everybody, this is the CDC data looking at estimated HIV incidence among persons 13 or older from 2010 to 2018 in the United States. And you can see that we've made some progress. We've had about an 8% reduction in HIV incidence. But again, I want to bring your attention to this, 8% from 2010 to 2018, okay? So this will be important as we go further. Although we do know that male-to-male sexual contact and heterosexual condomless contact share the majority of HIV new cases per year, and injection drug use and male-to-male sexual contact and injection drug use on the bottom have the lower association with new HIV incidents. It's important to know that these curves were either stalling, and in some cases, we will show you, and newer data showing that they're actually starting to tick up. And this is from the CDC as well in 2017, showing HIV diagnoses among people who do report injection drug use in the United States starting to increase in 2017. After all of those wonderful initiatives that we had with syringe services and other things. So if we remember, 2015 in Indiana was the first new HIV outbreak occurring among individuals who endorsed injection of drug use. And this was predominantly, this was all injection of oxymorphone, a long-acting prescription opioid in that area, very poor area, derived from Appalachia and Austin, Indiana, poor transportation. There, we remember the former Governor Mike Pence had put a moratorium on syringe services, and or actually it was no syringe services, they're illegal, and methadone had put a moratorium on methadone expansion, and buprenorphine was very difficult to find and often was from providers in Indianapolis or larger cities. And so as we know, we had 135 new individuals by April 2015 with HIV in a state that normally had maybe about 12 or 14. And I always like to point this out, over 45% at that time were female. By November of by that time, November of 2015, 181 new cases were identified. And when they did genotypic phylogenetic monitoring, it was clear that the majority were associated with sharing injection drug use equipment, as well as condomless sexual intercourse in that particular group. And there's been subsequent data from others, from Greg Gonzalez and others here at the Yale School of Public Health, to show that all of that could have been averted if we'd allowed syringe services at other harm reduction services. And I'll also state integrated medication treatment for opioid use disorder. Since that time, there have been significant other HIV epidemics. This is not exhaustive. I haven't updated them, but the bigger ones that we know are up north of me in Connecticut, in Massachusetts, Lowell and Lawrence, Massachusetts, that I'll discuss in a minute. Obviously, we know about Kentucky, Cable County, West Virginia, and importantly, Washington State and Oregon and other areas in Philadelphia, and also point out Miami, many other areas showing increased HIV epidemics. And as of this past year, Boston also had a new HIV epidemic among people who are injecting drugs. I'm just highlighting the Lawrence and Lowell one. It's an area where I grew up next to, a former mill towns, a lot of poverty, a lot of homelessness. And this was depicting the HIV epidemic occurring that they started identifying in people injecting drugs. And the light blue was related directly to injection drug use from the CDC data. Again, I want to point out 43% women, highly associated with injection of opioids and stimulants, predominantly fentanyl. And importantly, housing status, lack of housing, exchanging sex for drugs, as well as incarceration undermining the ability to access HIV treatment. So this is critical and kind of ties into what I described earlier, individuals being released to the community without having potential harm reduction services like syringe services, being able to access antiretroviral therapy, and also lack of integrated medication treatment for opioid use disorder. And if you don't know where these are about these towns are about 30 miles west of Boston. So not that far, but that time, the mayor at the moment had put a moratorium, didn't want to expand syringe services. Since that time, they've had a wonderful clinic that's been developed in integrated care, and have done a remarkable job on integrating treatment and seeing a reduction in HIV cases. This is just looking at the viral load of those individuals. And so again, referring back to what I discussed about how important it is to maintain viral suppression, not only for the individual, but also to prevent HIV infection. So as I'll discuss, treatment as prevention, that you can see in yellow, individuals who did not have their viral load suppressed to less than 200 copies, and it was highly associated with transmission within this cohort. This is just a summary slide. There's a number of individuals who've done work on this, but the point being that all forms of substances, including alcohol, can obviously increase risk of acquiring HIV. So our population is coming out of prison and jail, or community supervision, as we're talking about this topic, which have a higher prevalence of substance use, returning to the community without integrated care, can increase their risk potentially of acquiring HIV if they don't have that, but also among those who do have HIV, ongoing substance use can interfere with the care cascade. So inability to stay on antiretroviral therapy, which can then lead to viral load increasing, and of course, increased risk of harm, AIDS and non-AIDS defining conditions for that individual, but increased transmission to those who are not living with HIV. So this brings me to our goals. Our government, we have a wonderful Ending the HIV Epidemic plan that came out a couple of years ago. And the main goal is to reduce HIV incidence, so new cases of HIV, by 90% by 2030. So remember that graph I showed you, we've seen about an 8% reduction from 2010 to 2018. We want to get new cases reduced by 90% in just 9 years from now. And that includes treat everybody, or test everybody for HIV. There's no plans about how many times to test, but definitely test everybody. Treat, so rapid treatment. So as soon as you know their HIV diagnosis, initiating antiretroviral therapy, and achieve viral suppression, maintain viral suppression, and prevent. So immediate point of care HIV testing. If someone does not have HIV, initiate pre-exposure prophylaxis, PrEP, as well as note syringe service programs, SSPs, have those available, and of course, respond to outbreaks, identify that. It's an awesome plan. The issues are, we have forgotten about individuals who use drugs in this plan. And you remember our goal for HIV, if you do identify, is maintain, achieve viral suppression. Again, this is the treatment as prevention, undetectable equals untransmittable. There's a preponderance of evidence showing that anybody who has HIV, if you can get their viral load to undetectable, you cannot transmit the virus to an individual who does not have HIV. How are we doing? Again, this is data from the CDC. It's usually lags behind, which is an issue. We're in 2021. There's a little bit updated data, but it's not current. But if we look at, this is the care cascade for individuals based on their identified risk category for HIV. In the circle, I have individuals who identify as male injection drug use, female injection drug use, male-to-male sexual contact, and injection drug use. And if you look at the last column in each of those areas in the blue, this is the percentage of individuals who have HIV who have achieved viral suppression. And you can see it's around 50 to 60%. We want 100% if we want to end HIV. And so this is a huge issue. And again, if we want to really achieve a 90% reduction in new HIV cases, then we need 100% people with HIV having viral suppression. This is all the U equals U, treatment as prevention. It comes from a lot of work, but basically, this is a summary of data presented or reported back in the MMWR in 2016. But basically looking at the number, the risk of transmission from people living with HIV, and then the light blue are people known to have HIV, and in the dark blue column are the transmissions that occur for each of these situations. So people who aren't tested, who do not know their HIV status, you can see could be potentially associated with upwards of 40% of new transmissions. And this other one here, those who have HIV who are not virally suppressed could be associated with upwards of 20% of new transmissions. So those are absolutely critical. Identifying, rapidly treating, and PrEP and pre-exposure prophylaxis, as I said. But one of the major things that was lost and is not described is this just not a failure to understand different individuals and those who continue to use drugs and how to integrate care. And it's just not there. This is what I talk about a lot. I'm going to, as I said, talk about opioid use disorder treatment, but of course, we also need to continue interventions for those who use stimulants, as well as harm reduction services like syringe services. But here I just want to emphasize for opioid use disorder, we have wonderfully effective medications, FDA approved, that treat opioid use disorder, reduce opioid craving, reduce use, reduce overdose, improve mortality, and they also can reduce HIV and other infectious disease transmissions. And I'm just going to show you some data about how all these medications work individually, especially with the justice population. And then importantly with buprenorphine and extended release naltrexone, describes some work that we've done, which has also shown that it improves HIV viral suppression. So that kind of goals in line with the ending HIV epidemic plan. But this is just a brief kind of summary that, the different forms. Methadone, a full opioid mu agonist, so it's a full opioid, has had the longest history of effective treatment for opioid use disorder, works really well, but needs a licensed drug treatment program. There you have to be, might have a higher safety concern because it is a full opioid, but definitely reduces HIV risk behaviors and reduces overdose. Buprenorphine, 2002 became FDA available for people like me, not in an opioid treatment program, but I could prescribe in my HIV clinic, primary care clinic, et cetera. Multiple formulations, a sublingual tablets film, but also an implant Probufene that lasts 6 months, and then one injection Sublocade that lasts a month, and then also a new injection that'll probably be coming out in December of this year, which is weekly and or monthly. All can reduce opioid use, craving. And then extended release naltrexone is a complete opposite of that. It's a full opioid blocker. So it's like a long-acting naloxone. Is a monthly injection, intramuscular injection, requires no special training, can also treat alcohol use disorders, and has also been shown to reduce HIV risk behaviors as well as overdose, as I'll show you, and craving. This is earlier data looking at if you started methadone in prison system before one got released compared to typical referral at time of release or transfer on release. So and so they're color coded here. And the bottom line is that those who started methadone in prison before they were released in either of to the other two comparison groups had better, in this first column, retention and treatment. There was also a reduction in opioid use. They did look at recidivism outcomes, again, haven't demonstrated difference there. This was early work with a pilot that I did right after I started this, right after I was able to get my waiver for buprenorphine, and after the FDA had approved buprenorphine to be used. And I was really interested, well, why aren't we integrating opioid use disorder treatment for people with HIV coming out of prison and jail? And I was interested in, would people accept it? Because it was new. And would it improve viral suppression? If you remember, I'd looked at that earlier data of the Connecticut Department of Corrections and found out, people aren't able to maintain their viral suppression. What if we treated their opioid use disorder and, with their using antiretroviral therapy for the HIV, would that improve their likelihood of maintaining viral suppression? So this was a pilot study early on. I always remind people, remember, buprenorphine wasn't available at this time, or when I started this study. And I offered it. It was a small pilot. I'll show you about 90 individuals with opioid dependence at that time. The Department of Corrections at the time would not allow us to bring this into the facility, but on the day of release, if they were interested, we offered it to them. And this was a non-randomized control trial, so they had the choice of taking buprenorphine, using another treatment like methadone, which was the only other option, or no treatment. And the bottom line is we saw that there was a reduction in opioid craving immediately. So first of all, high level of craving at the time of release. The mean incarceration period was about a year. So emphasizing that point of why opioid overdose can occur with this group, because the craving is significant at the time of release, which can occur for multiple reasons. And the satisfaction with being able to start on a medication to help them was enormous. It was very high. Satisfaction went up. And then importantly, the return to opioid use was very low. I'll show you the viral suppression data in a minute. This is looking at extended release naltrexone, also known as Vivitrol, for specifically justice-involved individuals. These were individuals in the community, so not coming out of prison and jail, so community supervision. But it was the first study to look at the evaluation of extended release naltrexone on opioid outcomes for a justice-involved population. They compared it to treatment as usual or whatever was available in the community. And the bottom line was it reduced the mean time to opioid use for this population, as well as other opioid harms. And importantly, I like to point out that the group that received extended release naltrexone had no opioid overdoses, while the treatment as usual had 7, and that was statistically significant. So I think the bottom line is all forms of opioid use disorder medication treatment work. They work to reduce craving, they work to reduce death, they improve mortality. Also importantly, buprenorphine and methadone directly and quickly can decrease opioid withdrawal symptoms and can, if somebody also has a pain disorder, together can also reduce pain. I'm just putting this slide up here. I'm not going to go into details, but just wanted to bring your attention to there are quite a few long-acting formulations of medication treatment for opioid use disorder. The top 3 here are all FDA approved, and the bottom one is FDA approved, Brixadi, but won't be clinically available but until December of this year, so it's coming out. The last 2, Sublocade and Brixadi, are injectable formulations of buprenorphine, and the Probufene is an implant that you have to put in the skin. And then, as I said, extended release naltrexone has been around for a little while, is the opioid antagonist, so it's an opposite. And this just shows you differences. But the idea of potentially, when we're thinking about the reentry period, there are some of these that could, be considered as potentially beneficial for that, the potential lapse or linking to treatment, or potentially decreasing the concern about adherence to a daily oral treatment. We don't know, though, if one of these is better than typical treatment yet. So this is where I wanted to discuss briefly and importantly how this medication treatment for opioid use disorder can tie into HIV treatment outcomes. So this was an earlier study. I briefly mentioned it about our early success with when we offered buprenorphine to individuals coming out of prison and jail here in Connecticut who had opioid use disorder and HIV. I did show you the earlier data, but I was most interested in the primary interest and aim for that study was, would this improve HIV viral suppression? And not just maintenance of viral suppression, but if those who had not achieved viral suppression, if it would help achieve viral suppression. This is a 6-month study. Just to remind you, non-randomized control trial. So in green, this bottom last column are those who accepted buprenorphine and maintained on it for 24 weeks post-release, so 6 months. And then those in orange who started buprenorphine, but did not stay on it. And then in blue, chose no buprenorphine, and that could have included individuals who were on methadone. What we found is that the group who stayed on buprenorphine for 24 weeks had a statistically significantly higher proportion, so upwards of 60%, of viral suppression at a very low level at less than 50 copies per milliliter compared to the other two, so an odds ratio of 5.37. We later evaluated in one of these what are considered perfect gold standard studies, double-blind, placebo-controlled trial, where we used the injectable, at the time, only injectable formulation of FDA-approved treatment for opioid use disorder. Was extended release naltrexone, started before individuals were released, and then for 5 subsequent injections in the community. Again, it was placebo-controlled, double-blind, so no one knew what they were getting. And the group that actually received the medication, and that's in the tan here, compared to those in yellow who did receive the placebo, had a statistically significant, again, higher proportion, upwards of 60%, who achieved and maintained viral suppression at 6 months post-release with an odds ratio of 2.9. Of note, we did a similar study, same design in individuals with alcohol use disorder and HIV, and found the same outcome, also published in 2018. And then our group here in InStride with Katie McNamara, now a medical student, and others, did a huge systematic review and meta-analysis of looking at all studies that have been published, looking at the effect of medication treatment for opioid use disorder on infectious disease outcomes. And this is published this year. Over 8,000 articles were reviewed, and of those who met the inclusion criteria, the bottom line was that for HIV, which was the main one that was found, infection that was found to have enough data to evaluate it, initiating a medication treatment for opioid use disorder was associated in this meta-analysis of other published work, not just the work that we've done, that improved antiretroviral adherence and improved viral suppression. So this idea of integrated care can help improve HIV outcomes. So that's the bottom line. You know, it's just, we talk about this a lot, and the justice population is a wonderful population that is in high need, and really we need to do a better job of integrating these treatments. The problem is that few people are receiving treatment for opioid use disorder in the community. 1 in 10 are receiving medication treatment for opioid use disorder in the community. And I don't have time to go into it all, but stigma is a huge issue. Lack of clinicians wanting to take on this and treat. In the justice system, this is older data. It's starting to get better, especially in Connecticut. We're starting to see all of our prisons and jails is increased initiation of medication treatment for opioid use disorder in all the facilities, all 3 forms of treatment. But for the most part, sadly, many facilities don't offer treatment. And this is something that we want to change. I'm just briefly saying this, but the NIDA JCOIN initiative, Justice Involved research that was funded a couple of years ago, is specifically looking at how to reduce opioid harms for those involved in the justice system. So we have 2 grants. One is with Josh Lee and these collaborators here in 6 states, including here in Connecticut, where we're actually looking at how to integrate medication treatment for opioid use disorder for the justice population, particularly comparing extended release naltrexone and the long-acting buprenorphine on improving retention and care, but also looking at opioid overdose, as well as HIV, hepatitis C, seroprevalence. And that study is a direct partnership with justice involved individuals, as well as community partners here across the 6 states, and that study's started up. And then another one is we identified, that these linkages need to improve, and so we described this in a paper. It doesn't have the year here, but it was this year, 2021. International Journal of Drug Policy, looking at how we really need better implementation work of how to improve these evidence-based linkages, evidence-based services, so opioid use disorder across all the care continuums, not just HIV, hepatitis C, and others. So we have another JCOIN related award. This is partnering with, again, community and justice involved programs in Connecticut and in Texas, actually. And we are basically, this is a complicated slide, but looking at the implementation. So how to do this, how to work with partners, but also doing a randomized control trial comparing evaluations of Navigator, patient Navigator, to mobile health unit provision of opioid use disorder, as well as HIV PrEP and antiretroviral therapy treatment across 4 sites. I just wanted to say that it's not just me who's saying this about integrated care, that this was a National Academy of Sciences, Engineering, and Medicine workshop, which was called by HRSA to convene, and many experts came together saying that we really needed to do a better job of integrating these services, these treatments, opioid use disorder and HIV prevention and treatment. And we summarized that in an article in 2018. And then that later led to an actual study that was convened, and I was one of the members of that. And after interviewing several programs across the country that were either successfully or attempting integration of opioid use disorder infectious disease treatment, this was released in January 23. It's publicly available. But I think there were several recommendations that came out after reviewing that, which included removal of the X waiver, so allowing buprenorphine to be able to prescribe more, reducing stigma, having directed treatment like a Ryan White Care Act, to have wraparound services for people who had substance use disorders. Importantly, federal funds should be used to purchase syringe services. And then the bottom line was also criminal justice facilities should be able to offer opioid use disorder infectious disease prevention and treatment. And we summarize that in an article in JAMA. If you just want the quick view, it's a 1-pager. And then there's a lot of us. I'm an ID doctor. I've always felt we needed to integrate opioid use disorder, substance use disorder treatment, and HIV prevention and treatment. We're starting to see a lot of people take on this ownership, like David Sirota, Josh Barakis, Nick Savell, Ellen Eaton, really guiding people and really collaborating with our addiction medicine colleagues and others to increase awareness. And IDSA and HIV-MA, I was a part of this working group with many others across the country here, and came to a similar consensus that we need to strengthen collaborations and improve efforts to, importantly, if you read this article talking about the justice setting and others, to improve access to services. I just want to point out, I'm almost done. The new Biden-Harris administration and DEA has lessened, it's starting to get there, about increasing access to medication treatment for opioid use disorder. So mobile methadone and buprenorphine services to increase access to rural areas and underserved communities is I'm incredibly excited about that. I think that will help tremendously getting services and treatment, especially our individuals who are being released to from justice settings to very rural areas, which don't have access and don't have transportation to get to the urban settings where a lot of these programs are. So to conclude, I think it's pretty evident that we have a lot of individuals in the justice system who are either, at risk or living with HIV, have co-occurring substance use disorders. We need to do a better job of not interrupting their care, ensuring they have access to treatment for their substance use disorder, as well as HIV or HIV prevention services. And then we need to do a better job of linkage to those services in the community to help end HIV in this country, and also reduce overdose. So I'll stop there and I'll take any questions, and I apologize for going over.
Thank you so much, Dr. Springer. And I'm going to turn my video off because it's a little wonky here. So we did have a question from Holly H in the Q&A pod, and she says she has seen so much misuse of methadone in her personal life and wonders, in your professional opinion, is buprenorphine and the newer medications, quote, safer? Which meds have you found the participants or patients have better outcomes with? Yeah,
so it's a good question. I think one thing we don't have in this country is a shared decision model and a best practices, how to best match people with treatment. What I'm going to say is I've seen wonderful effects of methadone. It's been around the longest. It can be a very safe medication. It definitely reduces opioid craving, but it also has some, as I was trying to summarize quickly, but in that slide, it can have some negative effects, just like any medication, because it is a full opioid. If mixed with other opioids or other potential like sedative hypnotics that are being abused, that it can increase risk. It could have an association with overdose death, and there's also direct, EKG monitoring, QTC prolongation, other potential negative effects. But if used appropriately, and actually there's an increased calling from the National Academy of Sciences and others to increase methadone access through primary care settings where primary care doctors could help manage treatment as opposed to going to a separate clinic. But it can be a very safe medication. I think the issues are that there's a lot of other harm reduction services that we need to do. So if there is opioid use, fentanyl test strips, so people know what's in drugs. They could be searching for cocaine and on methadone, and also, unfortunately get fentanyl, so increasing overdose. Buprenorphine, one of the reasons why it is such a wonderful option is because you don't need to go to a special licensed treatment facility. You could get a prescription for buprenorphine, not have to go every day. It does have a better safety profile because it's a partial opioid. It's a partial opioid agonist, partial opioid antagonist, but it has a fixed dose, so you cannot a fixed effect. So it has a really high affinity for the opioid receptor, and you could start buprenorphine in a home induction process or directly, with somebody in your clinic. It could be in the street. It could be in, mobile health clinic. And you see, especially if they're there with withdrawal symptoms, immediate relief, like within a few minutes. And it's easy to titrate, and there's a fixed dose. You can't go above 32 milligrams, typically 24, definitely 16 milligrams can occur really quickly. It is definitely associated with very good outcomes. They've never, in terms of which one is better at opioid outcomes, again, we have to just, that has to have a nice shared decision process with what's best for the patient from safety profile, other comorbid medications they might be on, and what's useful for what's they can access. So a lot of methadone programs require inpatient or in-person visits. So I'll stop there. I could go on and on and on.
Well, thank you for that. And Holly says, thank you so much for your thorough answer. She truly appreciates it, and also of your time and information today. And we do have another question here from Antoinette, thanking you and asking, what recommendations do you have for frontline workers who carry caseloads of HIV positive people in urban settings who are active users with no intention of quitting drug use? What are the best harm reduction approaches in these cases?
Yeah, so, sometimes what a clinician or, social worker or others might think as the best treatment is not what that person is ready. And so they're ready for. So abstinence, as we know, isn't the only outcome. So safe use, teaching safe use, having ability for naloxone, teaching a partner, caregiver, family friend, how to help if one might potentially overdose, and then also safe injection skills. So how to safely use, and I think that there's a lot of evidence to support that meeting people where they're at. So, allowing a continued dialogue so that when somebody is ready, potentially, if they are ready for treatment, that they have an ability to safely ask for treatment. So there's a lot of programs, who do that. One, for instance, that I know here in Connecticut, Alliance for Living, really teaching that mantra. So there's also education about treatment of substance use disorder, access about where one can get treatment when they're ready. But if you shut a door on somebody and say, oh, we're not going to work with you unless you quit, that, of course, we do know increases risk for death. And of course, if they do have HIV or are at risk for HIV, also potentially shutting the door on access to effective treatment. So what I say to that is, it might be difficult because you know, as a clinician, you bring in what you know or what you want to happen, you know, but we also have to, and if we're really going to make headway, we need to understand, listen to individuals, be there for them when they're ready to, if they're ready to stop using, and if they're not, to safely help them so that they can avoid the direct harms of continued substance use.
Thank you for that. And we are at the top of the hour, but I am curious, and if folks can stay on, please stay on. This is coming from some earlier chat around PrEP access and use among people who inject drugs.
Yeah, so no one's getting, I can just say people who inject drugs are not being offered PrEP for the most part across this country. And we need to do a better job of doing that. So we need talking to people who inject drugs if they're aware of pre-exposure prophylaxis. We have 2 oral FDA approved medications for PrEP. They do reduce HIV. And we have an injectable formulation of PrEP that'll probably be FDA approved in January of 2022, cabotegravir. And so, you know, when we're speaking with or helping individuals who may use drugs, that's a wonderful opportunity to discuss pre-exposure prophylaxis. And you don't need a special license. You know, you just need to make sure that you're able to get HIV testing every 3 months if you were to continue to prescribe PrEP. Because if they do acquire HIV, then PrEP, the medication that is used for PrEP, which is also medication for HIV, isn't used in isolation and would increase resistance for those with HIV. But yeah, no, the PrEP care cascade is really dismal. For the most part, it's not being offered in individuals who are in the justice system, and it's not being offered for people who inject drugs, but it should be, and can reduce risk of acquiring HIV in that population, along with opioid use disorder medication treatment if they have that, syringe services, and other harm reduction services.
Thank you so much. And thank you for this wonderful talk. And as a reminder to everybody, please fill out your evaluation. Liz did put the link in the chat, and also check out our remaining series sessions that are coming up. And we really, again, thank everyone so much for your time today, and we hope to see you again soon. Thank you.
Thank you.